Thank you for the kind introduction, and again, a pleasure to be up here again. So we're going to switch gear to localized colorectal cancer, and really, instead of talking about chemotherapy, we're going to be talking about immunotherapy. And some of the data that I will be presenting today has set standards of care for rectal cancer, and some of the data is really evolving and suggesting that there will be some changes in the field in the upcoming future. And here are my disclosures. All right, so as a background, microsatellite instability is actually a good prognostic feature. And the reason I say that is that if you look at the stages of colorectal cancer, in early stage disease, about 20% of patients will be microsatellite instability high. And so these are hypermutated tumors. When they're hypermutated, they're recognized by the immune system. The immune system is capable of controlling these tumors and preventing metastases. And that's why earlier stages of colon cancer are enriched in MSI high. And because these tumors tend to metastasize less, you're going to see a lower frequency of MSI high as you go to stage 3 disease. So instead of 20%, it becomes 10 to 15%, and even less incidence of MSI high colorectal cancer in stage 4 disease, where it's estimated about 4 to 5% of patients with stage 4 colorectal cancer have MSI high tumors. We know that patients who have MSI high have a lower risk of recurrence stage by stage. So if you look at stage 2 disease with MSI high, risk of recurrence may be only about 5% of the patient population, 5 to 7%. But for stage 2 disease that are MSS without no microsatellite instability, your risk of recurrence, even in low risk stage 2 disease, could be somewhere around 12%. And even in stage 3 disease, there's some data that suggests that the recurrence rate is a little bit lower for MSI high than for MSS. However, even in these localized and local regional diseases, stage 2 and stage 3 colorectal cancer with MSI high tumors, even though they have a lower risk of recurrence, there remains an unmet need. Now, what this slide shows is the recurrence rate in patients with MSI high colorectal cancer that went on a perioperative chemotherapy with FOLFOX versus an adjuvant therapy as a control. And on this particular study, you can see that even with the good characteristics of the MSI high that the tumor has, still a fair number of patients will relapse despite using standard of care chemotherapy. The majority of these patients were stage 3 disease, although some of these patients probably were a stage 2 disease or a little bit misclassified as stage 3 when they were stage 2 because it was a clinical staging in the neoadjuvant arm. But at least in the adjuvant arm, we know that these patients' stages were correct and the majority were stage 3. And you can see that about 20% of these patients will recur despite using standard of care chemotherapy. So even though they have a little bit better prognosis, the adjuvant treatment is not extremely effective in this population in preventing recurrence. And it is felt that these MSI high colorectal cancers, at least based on stage 4 disease data, appear to be, compared to the microsatellite stable cancers, a little bit more chemoresistant. Now, why is there an interest in immunotherapy for this group of patients with MSI high? And remember, if we're talking stage 2, stage 3 disease combined, or stage 1, 2, 3, this is about roughly 15 to 20% of the population. Now, what you see on this slide on the top row is the infiltration of tumors with MSI high with immune cells. So the PD-L1 is overexpressed, CD8 is overexpressed. When you compare that to the mismatch repair proficient tumors, the MSS tumors, you don't see that inflamed tumor. The tumor cells are not as recognized by the immune system, and therefore these tumors are less responsive to immunotherapy when you use checkpoint blockade. And indeed, even in stage 4 disease with MSI high, when these patients are treated with doublet immunotherapy with a CTLA-4 inhibitor and a PD-1 inhibitor, we can cure these patients. You can see the top graph on the right. This is the outcome with nivolumab, ipilimumab versus nivolumab in MSI high colorectal cancer. About 70% of patients are without progression at the 3-year mark. Okay? And the majority of these patients will never relapse. So we really think about half the patients can be cured with dual checkpoint inhibitor with metastatic MSI high. The MSS population, on the other hand, does not respond in a stage 4 setting to immunotherapy adequately, although there is some work that we're doing in that area, particularly in non-liver metastases. So those are, however, the unmet need, because for stage 4 disease, that's 96%. For the stage 2 and 3 disease, that's still about 80% or more of patients. And we'll talk a little bit at the end of the presentation as to what's being done for rectal cancer with microsatellite stability. But the two classes of drugs that have been tested the most as far as immunotherapy are PD-1 inhibitors and CTLA-4 inhibitors. Okay? And these cartoons pretty much describe the pathways of each of the PD-1 activation and CTLA-4 activation. With PD-1 activation, you get more tumor escape. With CTLA-4, you attenuate the TCR response, and you also you get activations of Tregs. And so the inhibition of both pathways, PD-1 and CTLA-4, tend to be complementary, and we know from multiple tumor types that when you add a CTLA-4 inhibitor to a PD-1 inhibitor, you get better responses. So, with all that introduction, here are the questions that we will be covering. Number one, can we achieve a curative non-surgical outcome in primary colorectal cancers? What is the role of PD-1 targeting in MSI-high colorectal cancers? And we know it's approved for stage 4 disease and it's active there, but what's the role in stage 2-3 disease? What is the role of PD-1 and CTLA-4 inhibition in earlier stage colorectal cancer? And then what about MSS, microsatellite stable colorectal cancer? So let's start with PD-1 targeting. There's many studies that have looked at PD-1 targeting in microsatellite instability high colorectal cancer. This is one of them, the NeoPrism trial, which was performed and which was done in England. It included 32 patients with MSI-high tumors. Those patients were treated with 3 Q3-week cycles of pembrolizumab. So remember, I want to show you now the data as far as duration of treatment, 9 weeks of PD-1 therapy. And then a few weeks later, these patients underwent surgery. And what the study looked at is recurrence rate and also looked at, obviously, pathological response, right? How much the tumor melts away and what was the complete path response rate. So as far as patient characteristics, the typical, what you expect, high-risk stage 2 disease or stage 3 disease were included on the study. And this is the waterfall plot for pathological response. Quite impressive. You can see about 60% of patients had a complete pathological response with only 9 weeks of PD-1 therapy. Okay. Now, as far as immune side effects, with PD-1 therapy, you can still get colitis, you can still get hepatitis. However, the percentage is quite small. This is only a 32-patient population. It really did not uncover unexpected toxicities. Hypothyroidism, as expected, is quite common with this population. So this is not the only study that looked at PD-1 inhibition. Matter of fact, I am listing here 5 studies or 5 arms from 4 studies on this slide. And all of these were PD-1 inhibitors. There's no CTLA-4 here. And what we're trying to answer here is what's the complete pathological response rate? Absolutely no cancer cells left after treatment with PD-1 inhibition. And what I want you to note here is that the longer your treatment, the higher your complete pathological response. Obviously, if you're going to give a PD-1 inhibitor and do surgery 1 week later, you're not going to see complete path response. And since it takes time for the immune system to exert its activity, it makes sense that you have to wait a little bit to allow the immune system to do the job. And that's what we see with neoadjuvant PD-1 therapies. With 6 weeks, complete path response rate was 46%. You go up to 9 weeks, 59%. You go up to the 12-week mark, it's up to about 68 to 88%, although the 88% included a COX-2 inhibitor. So the message is clear. The longer the duration of treatment or the longer the interval between finishing treatment and surgery, both are important, will affect your complete pathological response rate. Now, even with PD-1 therapy, the purpose of this slide is to say the reason why we're not doing that with every patient with MSI-high tumor, you can still get immune-related side effects. On the IMHO-TEP study, you can see that DRESS syndrome occurred in 1 patient. There was 1 grade 3 colitis, 2 grade 2 hepatitis, and so these were 87 patients, so they do add up, right? And for some patients, you know, a right hemicolectomy may be worth it compared to having a 3% chance or 2% chance of having lifelong hypoadrenalism, or even a 10% chance of taking a Synthroid pill on a daily basis for the rest of their lives. But nonetheless, it's a proof of concept. This works, and perhaps the selection of the right patient makes sense. If this impacts disease-free survival, then it makes a lot of sense, right? So before we get to DFS, can we improve on the complete pathological response with adding a CTLA-4 to this patient population? And the answer is definitely yes, because you have randomized clinical trials that have looked at CTLA-4 plus PD-1 versus PD-1 inhibition alone, again in MSI-high colorectal cancer. This is a Chinese trial looking at sintilimab and IBI-310. IBI-310 is the CTLA-4, and it's the same duration of treatment, so 6 weeks versus 6 weeks of treatment with checkpoint inhibitors, and then about 5 weeks later they undergo surgery. And what this study showed is that the dark blue is the pathological response for the doublet, and the light blue is for the monotherapy PD-1. And obviously, you can see on this slide that most of the blue, dark blue is complete path response or deeper responses. Light blue, there's a fair number of complete path response, but there's more PRs in that particular setting. And indeed, the complete path response is 78% for CTLA-4 PD-1 versus 46% with PD-1 alone. And that 46% is similar to the other 46% I showed you with 6 weeks of another PD-1. So all of these data, the beauty about it, it's consistent. It's consistent. So where the problem lies is that if you add CTLA-4, you add more toxicities, okay? And then it becomes, is it worth it? And what patient population? So here you can see from the sintilimab trial and IBI trial, the orange are the grade 3 toxicities. They had a patient with grade 3 myocarditis, one patient with enteritis. Even on the PD-1 arm alone, there was one case of myocarditis. So how does this data compare to other approved, FDA-approved agents, namely nivolumab and ipilimumab? And this is the NICHE-2 trial, which was published in New England Journal of Medicine. And this is here, we're looking at only 2 doses. 1 dose of CTLA-4 and PD-1 together, that's day 1. And then 2 weeks later, a few weeks later, these patients get the second dose of nivolumab. And then 2-3 weeks later, they undergo surgery. So very short duration of treatment. Most likely, had these patients waited longer to have surgery, they probably would have even better complete path response rate. So what are the results here? About almost 70% of these patients roughly had a complete pathological response. 68% complete pathological response only with 4 weeks of therapy. And if you look at the patient population that had more than 50% reduction in their tumor, you can see that that's 98% of the population. So it is very unlikely for the disease to grow through immunotherapy here. But again, you have to weigh this efficacy vis-a-vis the toxicity. So if I quote the New England Journal paper here, if you look at dry mouth, for example, 9% of patients, thyroid dysfunction, 12% of patients, 3% of patients had adrenal insufficiency. So these are not fatal toxicities, but could be life-altering for a patient. So if you have a right colon MSI high, you could still do just a right hemicolectomy, and nodal negative, you don't need to do anything, right? And you don't want to subject those patients to immunotherapy. On the other hand, if you have a T4 tumor, clearly bulky nodal disease that you are really convinced maybe nodal PET positive as well, or something that this is really true stage 3 disease, perhaps that's a patient that requires immunotherapy. The beauty of this data is that the 3-year disease-free survival was 100%. So I showed you earlier that if you look at MSI high patients who get chemotherapy with perioperative and adjuvant FOLFOX, relapse rate is 20%. So this is a large sample size, almost 100 patients. So I think this data is convincing that there is a role for adjuvant treatment or neoadjuvant treatment for high-risk patient population. The question is, how do you identify them, knowing that imaging is not optimal in identifying stage 3 disease? Now, are there other data with immunotherapy doublets? Yes. Even LAG-3 instead of CTLA-4, this is the NICHE-3 trial, has very similar data, 97% objective response as far as pathological response, and the complete path response is also exactly what we saw in NICHE-2, 68%. So again, short duration of treatment here, followed by surgery. Same thing, you do not eliminate immune-related toxicities. There was hepatitis on the study, 5% of patients grade 3 and 3% grade 3 colitis. So how do we choose IO for this patient population? I think it's a personalized decision. You have to balance here the IO toxicities, including lifelong thyroxine replacement, rare but severe toxicities, colitis, hepatitis, myositis, and potentially death in some patients, and hypoadrenalism, versus the benefits of immunotherapy in reducing recurrence rate and potentially also avoiding surgery in some patients. And last, maybe making surgery more successful in the setting of a T4 disease where you would have had a positive margin. So those are the things to think about in this patient population. So the algorithm that we propose here is that for MSI high patients who are in good performance status, who are surgical candidates, if there are low risk features clinically, those patients should probably undergo surgical intervention. If there is high risk clinical features such as T4 and 2 disease, preferably positive PET in the lymph nodes with very bulky adenopathy, neoadjuvant IO with nivo-ipi could be considered based on the NICHE-2 data and their DFS of 100%. For patients who are poor surgical candidate, I think the decision is clear. Those patients should be considered for immunotherapy. So I want to switch gear now to rectal cancer because there is a standard of care now. And for MSI high rectal cancer, the standard of care is immunotherapy, not surgery. And that's really thanks to the work that has been done at Memorial Sloan Kettering, where they ran a large phase 2 clinical trial looking at dostarlimab, which is a PD-1 inhibitor in MSI high rectal cancer. The patients were treated up to 6 months. So the nice thing is we're not treating these patients forever. This study stopped at 6 months. And those patients were continued under observation. And as long as they had a complete clinical response, no surgery. If they did not have a complete clinical response, they could receive chemoradiation and certainly surgery. So the primary endpoint is overall response rate, the complete clinical response, and then if they have surgery, what is the pathological response as well. So if we look at the patient population here, 48 patients were enrolled. You can see that the majority of these patients were high-risk patients, T3, T4, nodal positive. And this is the swimmer's plot. None of these patients, when this data was presented at ASCO within the last year, none of these patients progressed. None of them progressed. But what you can see here, which is the orange dots, is the time of clinical complete response. And you have to keep that in mind when you're using immunotherapy for rectal cancer. It is no longer assessing complete clinical response around 3 months, and if there's still disease, taking them to surgery or chemoradiation. You have to wait 6 months or more, okay? The complete clinical responses happen typically at the 6 months, and you can see in some patients they did not occur till the 8 months mark. And the reason for that is likely because you get fibrotic changes endomucosally, and it's not having the same picture that you see with chemotherapy and chemoradiation. So this led the FDA to approve dostarlimab in MSI high rectal cancer, obviously. And the other thing that was presented from this study is, the ctDNA response, rectal response, endoscopic response, biopsy response, ctDNA. And what I want to show here is that, again, your 6 months mark is where you see your MRI responses. It happened mostly by the 6 months mark, 80% to 100% after 6 months. Same thing, endoscopic response, endoscopy, and the combination, obviously, that looks at both with the complete clinical response. Biopsies are negative earlier, and ctDNA is negative earlier. PET scan can also take time to become fully negative. So really wait is the name of the game here. So I'm going to finish with a few slides on MSS-CRC. I think there is a lot of interest in adding PD-1 inhibitors to rectal cancer. I think rectal primaries and colon primaries are more immune inflamed than metastatic disease, and that's why even though they're MSS, they can respond to IO therapy. This is a list of 5 studies that have added immunotherapy with a PD-1 inhibitor to a form of a total neoadjuvant therapy. The majority that have shown really striking good results are in the setting, interestingly, of short course radiation. And what you see here is that the complete path responses are somewhere around 40% to 60% complete path responses. This is amazing, okay? Because if you look at the data from Rapido, if you look at the data from PRODIGE 23, and these are the most coded studies in a total neoadjuvant setting, your complete path response is somewhere around 28%. So you're almost having an extra 20% by adding a PD-1. What we're missing is really impact on overall survival in these studies, okay? So is there a role of dual checkpoint blockade without chemotherapy, without radiation therapy? So some of this work has been looked at in pilot studies. The UNICORN trial and NEST trials looked at the combination of botensilimab, a CTLA-4 inhibitor, plus balstilimab, a PD-1 inhibitor. Botensilimab is a little bit more FC enhanced and supposedly stronger than ipilimumab. And what you can see on the UNICORN trial, looking at the MSS population getting PD-1 CTLA-4, complete path response was 4 patients, which is small sample size, 4 out of 14, 29%. And the partial response rate total is 71%. So not as good as MSI high, certainly not practice changing yet. And a lot of this work has been really pioneered by my colleague Pashtun Kasi, who ran these NEST trials when he was in New York, and they show kind of similar data as UNICORN. If you look at the NEST 1 and NEST 2 combined, roughly your complete pathological response rate is about close to 30% of patients. Okay. Now, again, my concern here is botensilimab has more immune-related side effects than ipilimumab, that the standard dose that we use. And we need a really a larger patient population to figure out the safety of these agents, so we may not be there yet, and certainly not outside of a clinical trial context. Now, where are we taking this further? So we have done a phase 2 clinical trial with FOLFOX plus botensilimab, balstilimab in stage 4 disease. We have shown very high response rates and tolerance. We've only used 2 doses of botensilimab. We're actually moving that as a total neoadjuvant therapy. FOLFOX plus CTLA-4 plus PD-1 in patients with localized rectal cancer, with the primary endpoint is to look here at the complete clinical response rate. If they don't have a complete clinical response rate, they can proceed to chemoradiation as of standard of care and surgery, or surgery without chemoradiation based on prospect data. So that's funded by the Gateway Foundation, and this study will be activated in the coming few weeks. So to conclude, I think the MSI high status should be determined on all colorectal cancer patients prior to any treatment, irrespective if it's localized disease or not. In localized MSI high colorectal cancer, the standard of care remains surgical intervention. However, we know that 6 weeks of doublet immunotherapy is associated with a high response rate of 95% and a complete path response of 70%. It can be considered in high-risk patients since it reduces recurrence rate, and it should also be considered in patients who requires it for downstaging for resection, and in patients who are not fit for surgical intervention. In MSI high rectal cancer, immunotherapy is the standard of care, and research is ongoing in colon and rectal cancer patients with microsatellite stable disease to determine the role of CPI in definitive and adjuvant therapy. Thank you.